very pure cystic disease for the most part. And so what you see is this. You see, and this is a fairly severe case, where you have these holes throughout the lung, everywhere, very diffuse. And again, this is a relatively severe patient who we ended up transplanting more than 2 decades ago at University of Michigan. Now, sometimes these cysts can grow to a fairly large size. Again, this is a more extreme case. But I think you can imagine that when you have these large cysts like this, if one of those bursts, it's like a balloon can lose its air and you can get a pneumothorax. And so the pneumothoraces that are so common with LAM are really due to rupture of these cysts. This is just another example where what you see is just these small cysts. Now, they're relatively easy to see. I mean, I think that cysts in LAM they're smooth and rounded, and in between the cysts, the lung looks totally normal. So here's one, I think, where you can definitely see lots of cysts, but much of the lung is quite normal. And we have some patients where they literally only have 3 or 4 or 5 cysts in each lung, and others that literally have hundreds. And I think that really is associated with more severe disease. So here's a patient that I follow who has really fairly diffuse cysts everywhere, and only has about 20% lung function. Not surprisingly, given this is her lung just showing cysts pretty much everywhere. So the one thing about LAM, I think, it's very typical of any biological disease. It's incredibly varied. And so when people talk about rates of progression, there are no data really to show you what's my expected rate. How do I know? The answer is you don't. And we'll show some data in that regard. And I think the best way to look at the rate of progression in individual patients is to get sequential tests. Now I'm going to show you some data on individual patients as well as large published series. And now that we have sirolimus, I know there's a speaker on sirolimus later, or LAMposium, I really think it's more important than ever that you see someone on a regular basis who's a LAM expert. And by that I mean no less often than 6-month intervals, and I'll show you why. Now it turns out that lymphangioliomyomatosis, or LAM, by definition involves the lung. But it turns out that you get these other growths of smooth muscles and blood vessels, what we call angiomyolipomas, or AMLs, and you get them in places outside the lung in sporadic LAM. And so we're talking about kidney, about 40 to 50%, uterus, ovaries, and it turns out that these AMLs are also seen in virtually 90% of patients who have tuberous sclerosis. So these AMLs are seen in common with tuberous sclerosis, although more commonly, about 90%, as well as LAM, about 50%. And then in LAM, they are virtually mostly seen in the kidney, and generally in female organs. So that would be uterus and ovaries, occasionally, but uncommonly, spleen and liver, pelvic lymph nodes. And this is just some data just showing that if you look at series, published series, this is the overall rate of AMLs in patients with sporadic LAM. Again, the incidence is higher in patients with tuberous sclerosis-associated LAM. Where do you think you're going? Well, this is the question when you have a new patient with LAM is, well, how do you know what the prognosis is? And the answer is, on day one, you usually don't. What we know about LAM is, of course, it's progressive. It's usually very gradual, over decades. You can get respiratory failure, and in fact, some patients will have progressive disease and will either die of respiratory failure or may require a lung transplant. So how do you know whether you're going to be in that situation? And I put in no proven effective therapy, but I will say that in my opinion, sirolimus can be very effective in selected patients. And I think the reason we can't really say much more about that is the data, as I'll show you, are still limited because of the rarity of this disease. The prognosis of LAM is highly variable. Of the 57 patients that I follow, I have patients who were diagnosed back in the 1980s and 1990s who have relatively mild to moderate disease and have very little progression, considerably less than 1% per year. And then I have other patients who come in, usually during or following a pregnancy, and within a year or two are on oxygen. So why does that happen? Well, it's not clear why that happens, but I'm just going to show you. I think if you go back and you look at the first studies of LAM, which were published in the 1970s, and the first large series was published in 1990 in the New England Journal of Medicine, these actually antedated the availability of CT scan, meaning that the diagnosis of LAM was usually made relatively late in the game. So by the time they presented, they often had a fatal respiratory failure. The early studies in the 1970s were actually autopsy series. And as I'll show you, in 1990, the study was about 25 years with the Mayo Clinic at Stanford experience, only 32 patients with LAM. And the early studies suggested that survival was not that good, but I think all the recent studies suggest that survival out of 10 years or more is consistently greater than 90%. So one of the other things I will point out is that patients who have LAM in the context of tuberous sclerosis tend to have a more benign course than patients who have sporadic LAM. So I think that's another issue, and there are certain parameters or certain stigmata or abnormalities you see in tuberous sclerosis you don't see in pulmonary idiopathic sporadic LAM. So I think it's important as physicians, if you have someone who's tuberous sclerosis, you can pretty much say that they're going to have less severe LAM in general in the lung than sporadic. And this just shows some data. This is the NIH registry. JRU published this data in 2006. Now you can see this is the largest publication of LAM, and this is the NIH registry. They had 230 cases, which seems like a fair amount, but again, most of the studies, as I'll show you, worldwide have comprised numbers of patients of between 50 and 60, 50 and 70. They're not very many cases. Excuse me. But what you can see is that in sporadic LAM, again, this is LAM without tuberous sclerosis, you have a lower FEV1, so you have less lung function. You have less renal AMLs, that's kidney AMLs, whereas about 30%, whereas tuberous sclerosis is about almost 90%. And the 15-year survival rates in sporadic LAM is around 66%, and about 77% with tuberous sclerosis. Now you have to be careful when you look at survival rates. Survival rates really occur at the time of diagnosis. So if you don't make the diagnosis until someone is very late in the game, which is often the case with rare diseases, then in fact they may have had the disease for 10 or 15 years earlier than that. So I think you have to be careful about survival rates of rare diseases. I just want to share with you, this is the first really series of patients with LAM, published in 1990, New England Journal. And between 1976 and 1999, at the Mayo Clinic and Stanford, two of the leading institutions in the United States, they only had 32 patients. Think about that. That's why it's become relatively difficult to study this disease. And I think that the LAM Foundation has been really pivotal in getting grant support and really pushing this effort. I don't think that the NIH registry would have happened without the LAM Foundation. But in the early study, in this study from 1990, 78% of their patients were alive at about 8.5 years after diagnosis. And so for patients with LAM, they said, gee, is that all I can expect? And the answer is no. Again, this study came before they even had CTs, and CT scans allow a much earlier diagnosis. And as I'll show you in subsequent studies, the survival is much better than that. But again, this is one of the early studies, and this will be called a retrospective study. After the Mayo Clinic Stanford series was published, the Asian countries, Japan, Korea, Taiwan, went back over all their cases of LAM in those three countries, and they were able to get together only 46 patients, which at the time was the largest published series in the world. And they had only about 38% survival at 8.5 years. So again, it looked like it wasn't that good, but watch out, Maurice, it may be a trap. The bottom line is those studies really looked at patients who often came in late in the game, often in respiratory failure, and they really are not relevant to patients who now come in as a new patient. So I'm going to show you very quickly some studies. This is from France. Now recognize that this was 1999, 69 patients with LAM. That's the entire country of France. That is all the cases they could find in France over a period of over 15, 20 years. 69 patients. So you can see how it's hard to study this disease. But they had a 5-year survival of 91%. They had a 15-year survival of 71%. Of course, survival counts, deaths from anything. If you get hit by a bus, it's, you die, whatever. So bottom line is that the survival rates certainly have improved compared to what the initial studies. And this is a study from the UK. This is all of the patients in the UK from the registry. And again, they only had 57 patients with LAM from 1995 to 2003 in the UK. 10-year survival from the onset of symptoms was 91%. So if you look at both of those cohorts, you look at now 10-year survival rates, you're talking somewhere between about 80 and 90+%. If you look at the US data, this is the data from the NIH cohort, 227 cases, same survival, over 90%, whether or not they had a pneumothorax or not. So 91% if they had pneumo, 92% if they didn't, so really no effect. And this is 15-year survival. So again, the prognosis is not nearly as grim as we think. However, there are some circumstances which can be associated with a worse prognosis. And I think one of the things that was known early in the 1970s is that pregnancy really exacerbated disease in some, but not all women. This becomes a really difficult issue in terms of medical advice, I think. But pregnancy or any kind of estrogens by pills for whatever reason can exacerbate the condition and are not recommended. This is some data from the UK, again looking at what were the factors associated with a more rapid progression. And one of the factors was if you smoked, you were twice as likely to have more rapid progression if you smoked. But the strongest risk for rapid progression was pregnancy. So your risk of getting a rapid progression went up by 2.7 times if you were pregnant. Now, the diagnosis of LAM historically was made by pathologists under the microscope. And when looking at things like rate of progression and prognosis, because that was the subject that I was asked to talk about today, one of the things that came out, again, this is data from the US, and they had surgical lung biopsies from 105 women with LAM. And they do what's called a quantitative score, so they did very meticulous scoring. And I don't think it's surprising that those who had more severe disease had a worse survival. And LHS1 means relatively mild disease, and they had 100% 10-year survival. The worst biopsy features, what they call LHS3, had a 10-year survival of about 50%. So I think it's not a surprise that people with more severe disease on lung biopsy have a worse outcome. The fact is, nobody does biopsies anymore. Anybody here had a lung biopsy for LAM? Okay, several actually. I think in the next 5 years, biopsies will probably never be done for LAM, with the exception of if you do it in bats for pleurodesis, for example, because the diagnosis is so obvious with CT scan. Bummer of a birthmark now. Well, some of the things you want to monitor is you want to monitor those aspects of your lung. And you can't run around getting CT scans every week or month because of the radiation impact. But I think CT scans are without any question the best imaging modality of patients who have LAM. Pulmonary function tests are easy. Sometimes they're difficult for the patient to perform, but there's no radiation effect. There's really no downside. And a very simple parameter, the FEV1, which can be done in physicians' offices, is highly predictive of outcome. Now, in addition to CT scans of the chest, we do recommend imaging of the abdomen and pelvis to look for AMLs, these smooth muscle proliferations, in the abdomen or in the pelvis or uterus. And so, generally, in my first if I have a new patient, I do get a pelvic abdominal CT scan early in the course. If they don't have something on abdominal CT, I don't repeat it. I will use follow-up ultrasounds, which have no radiation. Or if they have a single lesion like a renal AML, which we often see, you can image it by ultrasound. I use the ultrasound rather than CT, but CT is a better test. It just is radiation. And then in terms of the lung function parameters, there's really only two parameters that I think are relevant. I mean, there's a lot of fancy stuff you can do, but I don't think it really helps. And the FEV1 is a very simple test. It just is how much volume you can get out in 1 second. And it's very reproducible in individual patients. And the other one is what's called the FVC, or the forced vital capacity. And so all the studies from Miles trials and else will always look at FEV1 and FVC. So I'm sure, how many of you are familiar with the FEV1, at least when you've seen it? Yeah, I mean, you're all. Okay, now this is the mean annual decline. This is data from the NIH registry. This is the largest data set that's ever been published in LAM. And delta means change, and this is mean annual change in FEV1, or mean annual change in DLCO. And you can see that this large cohort in the NIH, the average change in the FEV1 was 1.7% per year. It's not very much. Because when you do an FEV1 in a physician's office or in a hospital, you can see rates of difference from just day to day of 4 or 5%. So it's hard clinically as a doctor to know, does 2% mean anything? But if you follow these patients longitudinally, which they did over 4 years or so, they were able to show that on average, LAM patients lost less than 2% per year, DLCO about 2.5% per year. So that's kind of what we expect in terms of the average patient with LAM loses about 2% per year. However, there are some people that lose it a lot faster than that, and that's why you have to be a little more careful, because not everyone loses it at 1.7%. There are some that lose 50% in a year, and I'll show you that. So this is a patient of mine who shows a little bit of LAM cysts in the upper lobe. I think as you go down, you see these huge holes everywhere. Same patient. Same patient. All these holes, all these cysts have pretty much replaced the lung, and you can see that there's more holes here than there is lung. And when you get to the bottom, there's almost no lung. I mean, this is all holes. So this is one of the more serious cases. Now, I just want to show you what happened with her, because she's an example, I think, of why people with LAM need to go to a LAM clinic, and they need to be followed by someone who knows what to do. This patient presented in 2000 with a renal AML, one of those smooth muscle proliferations. And then 14 years later, she had her first pneumothorax on the left side. Prolonged air leak, chest tubes for days, ended up getting a talochlorodesis, which, by the way, should be done early. I mean, if somebody has LAM and they have a pneumothorax and need a chest tube, you probably should do a bad stent, because they just leak and they leak and they leak. So if you're going to put a chest tube in, just do it and do a talochlorodesis right then. And then about 3 or 4 months later, she developed another pneumothorax, and again drained with a chest tube, so they did a talochlorodesis. And I saw her for the first time in November of 2005. And the reason I saw her then was for an evaluation for a lung transplant. At that point, now 2005 was 3 years before the sirolimus rapamune study was published. And at that time, the data on Depo-Provera progesterone was somewhat controversial. It was considered that progesterone, and this was a Depo-Provera, might be helpful. It probably isn't. Put her on that. And even though I always ask these patients to come back, I always say come back in 3 or 4 months. Your doctor's probably never seen another case, and they always, that's true. I think I've never had a patient that a doctor seen more than 3 cases. So, you know, it seems silly to me, but she didn't come back for about 3 or 4 years, and now she comes back. And on the day she came back, I started sirolimus. This was March of 2010. I think had I seen her in 07, I probably would have started, because I'll show you some other examples. But look at this. I mean, this woman had 100% vital capacity, 83% FEV1 in 2003 when she had her first pneumothorax. And I saw her here where her FEV1 was 40%. She was referred for transplant. I said, transplant really is too early to list her for transplant. Just have her see me every 3 or 4 months and we'll reevaluate. And then I next see her here when she's at 20%. And she stays here. That's where she lives now. She lives right around 17 to 20% lung function. Just saw her on Monday. And she's still running around 17%. So I think she's an example of one of the most rapid loss of lung function that I've seen of the 70 or 80 patients with LAM that I've seen in my career. This was really a very rapid one. Now this is another one. This is a woman who presented in her young 30s, 31, with a pleural effusion, which turns out to be chylus, which is one of the classical features of LAM. In November 2005, she had a surgical biopsy, drainage, and pleurodesis, and I saw her about two weeks after the chylus effusion and consultation, and said, come on and see me every 3 or 4 months. It's too early now to assess, lung function. You just had a chest tubing, you just had surgery. And so typically, she ended up seeing me in January of 06, and then I didn't see her for two and a half years. She lived about 200 miles away. She saw her own pulmonologist. And then she shows up in January of 2008, at which time I started sirolimus. Now, January 2008, January 10th of 2008 was when the sirolimus AML study was published. And this is the advantage of being at least relatively current. So I started her, and this is the most amazing response I've ever seen. And I'm not even sure I believe it, except I've seen her now enough. There's where I saw her to start. I saw her in 06. This data was from San Diego. I didn't see her then. But you could see her FEV1 was over 60%. And I saw her here. I hadn't seen her for a couple of years. And there she was now at about 44% FEV1. Huge drop. So that day I said, that's it. We have this study which has just been published. We're going to put you on sirolimus. And amazing. This is the most dramatic response I've ever seen in my career. This was January of 8. This is July of 2008. By July, she was up to 80%. And she's kept up around 80% with sirolimus. So to me, this is really a good example of a very excellent, unbelievable response to sirolimus. Now this is another woman I have who's 22-year-old, and she developed pneumothorax both sides during pregnancy. So in 2008, she had bilateral pneumothoraces during pregnancy. She had no recurrence post-pleurodesis. She was referred to me in January of 2012, at which time I immediately started sirolimus, which I don't do, by the way, most people. I would say in my practice, maybe 10, 15% of my patients are on sirolimus, the others are not. Basically, she's remained absolutely stable around 60%. Now, I don't know whether that's because of sirolimus or maybe she would have anyway. I don't know. There's no way of knowing. But this is a woman who had relatively aggressive disease, and at least we can say that she's been absolutely stable on sirolimus. And so the question is, what other kind of new options are there? What are the treatment options? I'm not going to spend any time in this as someone who's going to, discuss sirolimus today to your group. And I just want to say that what rapid immune sirolimus does is it slows down smooth muscle proliferation, which is the dominant lesion in LAM. And this is a very simple study. The first study was 25 patients who had renal or abdominal AMLs. And the majority of these patients had tuberous sclerosis. Only about half of them had sporadic. But what they did is they gave them 12 months of sirolimus. So they all got sirolimus for 12 months. And then in 12 months they stopped sirolimus. And what they measured was the volume, the size of these AMLs at 12 months. And lo and behold, it went from 100% baseline at 12 months was down to 54%. So it shrunk by half. They then stopped the drug, waited another year, and repeated it at 24 months, so 12 months after stopping the drug. And it's up to about 86% of the initial volume. In other words, it had a very favorable effect in shrinking the tumor, but it was not a sustained effect. Now, it turns out that there are 11 patients who had pulmonary LAM in that cohort. And amazingly, all of a sudden, the FEV1 actually, instead of going down, which it normally does by about 90 to 100 cc's a year, it actually went up 118 cc's in 12 months. This is the first study to suggest that giving sirolimus actually improved lung function. Again, findings clearly associated with shrinkage of the AML size, improvement of FEV1, but the effect was not sustained after the drug was discontinued. Well, it's cold again. Well, so Frank McCormick, who was an author in that first study, actually was the first author in the second study, which was the Miles trial. Again, very quickly, same kind of design, except now half the patients got placebo, half of them got rapamune for 12 months. The drug was then stopped. They were observed for another 12 months, and I'm going to show you what happened. Again, the endpoint being FEV1, which is a lung function parameter. And let's focus on the FEV1 only because it gets confusing. The placebo group dropped in 1 year by 134 cc, whereas the treatment group with sirolimus, rapamune, actually improved by 19%. And 19% isn't very much, but the difference between the placebo here and rapamune, 153 cc is a pretty significant change. And so what we can say, and then what happened, so at 12 months, sirolimus was associated with improvement in lung function. Patients actually felt better. And however, when they stopped the drug, the rate of change was exactly parallel in the rapamune stopped patients compared to placebo. So again, it was beneficial at 12 months, but it was not a sustained effect. And that settles it, Carl. From now on, you're getting only decaf, maybe coffee. The problem with all of this is sirolimus is an immunosuppressive drug. It's been used in transplant patients, has a lot of side effects potential. And if it's not a sustained effect and you have someone who's 30 to 35, are you going to keep someone on this drug for like 30 years? Or, so I think we're still wrestling with this because of the need for long-term use. And I think nobody can tell you what the right strategy is. Though I think common sense, if you have someone who has severe progressive disease, you probably should consider sirolimus so you don't lose further lung function. And that's what I do. If I have someone who has LAM that's relatively mild and not terribly limited and has not shown progression, I do not give on day one or rapamune. However, if at 3 months, 6 months, 9 months you can see a steady decline, then I will consider rapamune at that point. And the only other thing I'm going to talk about in no more than a couple minutes is transplant. I have in my career had about 10 patients who had LAM who had transplants. This is one patient where you can just see tremendous holes everywhere. This is the non-affected transplant lung where there's no holes. And this can clearly be life-saving, and certainly in someone who comes in with 20% lung function or less, they can have totally normal lung function and have a great quality of life. The problem with transplant is about a 50% mortality in 5 years. So it's not one of these things that, why don't you get a transplant? And I think it has to be thought out really clearly. And that's why I think that when you have LAM patients, it's important that anyone in the LAM clinic also be a transplant doctor, because there is a point, I think, where for some patients, transplant is the option. However, it has enough mortality and morbidity that we only recommend transplant, very specific indications. Well, I think this says, okay, stranger, what's the circumference of the earth? Who wrote the Odyssey, the Iliad? What's the average rainfall of the Amazon basin? Barton, fool, you can't shoot first and ask questions later. I mean, the whole point of this symposium and research, et cetera, is to really try to figure out what are the best ways to approach land in a sensible, common sense way. I think transplant certainly has a role in some patients. I think Rapamune certainly has a role. And I'm sure there will be newer drugs out there with different studies prospectively. So I'm happy. I'm done with my remarks. I think I have a couple, 3 minutes for questions. Do I? I think I have about 3 minutes, 5 minutes. I don't know. Yes.
Hey, a couple questions. There was a slide that said progesterone at 2.2%. Is that an increase?
Now, the slide about progesterone showed the original studies were suggestive. Well, maybe if you gave progesterone, because it is anti-estrogen effects, maybe that might be beneficial. And in fact, when the studies were looked at, it had the opposite effect. The patients who were on progesterone either did the same but did worse than patients who were not on progesterone. It may have been a selection bias. The study that I showed you looked at all comers who were on progesterone versus those who were not. And the odds-hazard ratio, 1 is no effect, less than 1 is benefit, more than 1 is harm, and the odds ratio for progesterone was over 2.2.
So she was on an estrogen birth control, but they obviously switched her to now progesterone birth control. Is that the right way to be?
Well, you need to have, obviously, excellent birth control because estrogen is really the worst thing. I think what we would say about progesterone is it probably doesn't do anything one way or the other. And I think when you look at retrospective studies, like because that's what that study was, about half were on progesterone because progesterone was recommended back in the 1990s. And when you looked at those on progesterone, they actually did worse than those off. But it may be that the doctors selectively gave progesterone in the worst cases. So I think, and I have one patient from the 1980s who had an unequivocal response to progesterone. No question. She had large, multiple chylus effusions of the lungs, ascites, and this is like 1980s. And I put her on progesterone and it went away. It's the only one I can ever say that I absolutely think worked. The other ones that I've treated, I've never seen a response like that. So, it's like anything else. I think some people are going to be a responder and some won't. So I think right now, I would say progesterone is, if it's an integral part of birth control pills, then it's okay. But if you use it because they say, let's try progesterone for LAM, I think that's a bit silly. I think that if you're going to use something for LAM, sirolimus is a drug to use. Yes?
You mentioned that sometimes AMLs are found in the uterus. Are they sometimes mistaken for fibroids?
I think they probably could be. I'm sure they are. If you look at the reports from lung biopsies, for example, most of the time the people, the surgeons, when they describe it, looks like emphysema. And oftentimes the lung biopsy reports say cystic changes that don't really comment if you're not looking for it. To look for LAM, you have to do specific HMB45 staining, and if you don't think about it, you'll never do it. And there's very few cases of LAM picked up, say incidental fibroids. Of women who have fibroids is very common. Again, LAM, you're talking about 6 cases per million, max. And of those, probably half of them might have, incidental AMLs in the uterus. And most of the time, they're not really associated with pain. Most of the time, they're incidental findings. So there's no data on this. There aren't enough cases to have. But I'm sure that's true. I'm sure that if you don't look and you don't do the biopsy, you don't do the HMB45 staining, you probably miss it. Good point. Yes.
So a fibroid in your uterus, do they just keep growing because they're?
Well, fibroids can. Again, fibroids is not AMLs. Fibroids is totally different. It's a benign growth, and it can cause pain, and so fibroids is common in women. It's a benign growth. It's not AML. It has nothing to do with LAM.
But if you have LAM, I had 35 surgeries with fibroids. I had to have hysterectomy when I was 24 years old. and couldn't use estrogen replacement, they actually think I had this when I had our son 38 years ago.
Yeah.
Because I'm not using the estrogen replacement here, but the last 8 years, they know I definitely had this.
Yeah, well, that's.
And I
you-
kind of feel,
Well, I think that's true. I mean, I think most people who have LAM are misdiagnosed because, I mean, when you think about it, the average physician is never going to see a case in his or her career, ever.
between my breast and my uterus was nonstop.
I mean, you just never see it, so they don't recognize it. And I can understand why. I mean, if it's 6 per million, doctors don't see 200,000 patients, so they'll never see it. It's only one. So you can see why there's often a misdiagnosis. Yes?
Hi, do you recommend follow-up CT scans after initial diagnosis?
Yeah.
For
I used to do a CT scan initially, and if they have totally normal lung function or minimally abnormal, I repeat a CT at 1 year. If their pulmonary function tests remain normal, I may do it every 2 years. I don't do it a lot. I think CTs, I think we overestimate the negative effect of radiation. Not that much, but I think the main thing you should do is you should do lung function tests. And if your lung function studies look like they're getting a dip, I think the CT may corroborate that. And I think the same goes for the abdomen, so I always get an initial, just one-time CT of the abdomen and pelvis because it's much more accurate than the ultrasound. But if you have a single lesion and you can identify it by ultrasound, then the ultrasound becomes the main thing. But yeah, I mean, you can only do so many CT scans, so I don't think that CTs should be done as much. But I really believe, and I've recommended this for years, and often the people who land, they come from 200 miles away, and well, can my doctor do this? I say no. I mean, has your doctor ever seen a case other than you know? Well then, but they don't want to come back sometimes. So I think a minimum of every 6 month lung function should be done. For new patients, I usually say 4 months for the first year. That's pulmonary function test, lung function. Yes, your question.
My question is about DLCO. I know they didn't follow it so much in the Miles trial and had results. It was more the FEV1, but there's this percentage of patients whose DLCO is in the low range, but their FEV1 is still pretty good. And have you seen a change with RAPA on that? And can the change take place, a year out, a year and a half out, whereas most changes with RAPA, you get that increase and then stay.
Well, nobody knows. I mean, the Rapamune was one study. The DLCO did not change in the Rapamune study. The FEV1 did, the DLCO did not. DLCO is a much more variable test, so it's less accurate than the FEV1 for a whole bunch of diseases. So if you want to follow someone for efficacy, FEV1's a better test. For interstitial lung diseases that are not associated with airflow obstruction, that is, the FEV1 is often normal. The FVC, vital capacity, is better than DLCO. DLCO is the most often affected. It is often the most severely reduced in lung diseases. But there's a lot of variability from test to test. So you could come in tomorrow and your FVC will be within 2%, FEV1 2% of where you started. The DLCO may be 8% different. It's a much more variable test. So the DLCO is not as good a test in terms of its accuracy. It's a more sensitive test, but it's not used as a marker. Did I answer all your questions? Or did I miss something? Yeah.
Have you seen a change in that in any of your patients? And did you have?
Oh, I don't know. I mean, we haven't had enough. I probably have 10 patients I've treated. I mean, I'm sure I have, but I don't really think an anecdotal case like that would mean anything.
Or the change in the use of RAPA, it seems to be like an increase within a short period of time from starting, but.
Well, I showed you that one case. It was up within 3 months. It went up dramatically from 45% to 75% within 3 months. I mean, the Rapamune study was done in 12 months. There aren't any studies saying that like 4 weeks or 6 weeks or whatever. So there are no such data. And the studies from my experience as well as the Rapamune study, the FEC goes up and the FEV1 go up. They both go up. If it's going to work, it's going to go up. There are no data in terms of how long it takes. And again, no studies looked at you know, we don't really know how long it takes, but I've certainly seen it happen within 3 months. We don't usually repeat it any earlier than 3 months for chronic diseases. You know, when you use a drug like rapamune, let's assume you did a test at a month and it's up. What are you going to do? You know, you're going to continue the drug. If it's not up in a month, what are you going to do? You're still going to continue the drug because it isn't long enough. So those studies are not available, and they never will. Okay, thank you very much. I'll be happy to take questions.